Okay, awesome. Hi, everyone. Thank you for being here on this lovely Friday. I know it's really warm outside, so appreciate everyone being here today. Thank you for coming to our May Tea Talk series, where we'll be talking about health disparities among Asian American groups during COVID-19. And we'll have amazing presenter Jake sharing his findings. I'm excited to hear about that. So really quickly, my name is Sophia. I am the program manager here at Asian Women for Health. Asian Women for Health, we are a nonprofit dedicated to advancing the health and well-being of Asian women and people from diverse, underrepresented backgrounds through community engagement, education, and representation. And really quickly, I always like to share some vaccine updates. Just remember to get your booster shots for COVID-19 at your local pharmacy if you haven't done so already. And also very excited to share that the hepatitis B vaccine is now available. Hepatitis B is one of the most prevalent sort of diseases that are currently in API communities, and they've been giving out this vaccine in many Asian countries. So I'm excited to have this now in America. And now I will pass it over to Jake to introduce himself.
Good afternoon, everyone, or good morning, wherever you are. My name is Jake Ryan Sumibcay. I am currently a postdoctoral fellow at the Harvard Chan School of Public Health. I'm also an incoming assistant professor at the University of Hawaii at Manoa in the Department of Health Policy and Management. And I'm also a research affiliate for the Happy Lab, or the Healthy Asian American Pacific Islander lab, and it's a collaborative of researchers and community organizations based in Southern California to focus on the health and well-being of the Asian American, Native Hawaiian, Pacific Islander populations. Today, I'm going to share findings from two projects that I've been affiliated with. But first, I want to thank Sophia and Angel. Happy Asian Pacific Islander Heritage Month and Mental Health Awareness Month. Thank you all for the opportunity to join you in this tea talk. And as I mentioned, I'll be sharing some insights on some two community-driven projects that I've been privileged to be affiliated with. And these projects focus on the health disparities found among the diverse Asian American groups during the height of the COVID-19 pandemic, particularly in California and the greater Los Angeles area. I want to acknowledge that the diverse experiences of the Asian American groups during COVID-19 and the core focus of these projects is the collection of disaggregated and representative data to understand the specific community needs. I also want to acknowledge the principal investigators of these projects, Dr. Melanie Sabato-Liwag of Cal State Los Angeles and Patty Kwan of Cal State Northridge, two very amazing Asian American women that I personally look up to. And they have been the leads for not only the projects that I'll be sharing, but also for building a collaborative of the academic researchers and community members focused on improving the health and well-being of the AAPI communities. So in today's presentation, I'll be sharing an overview and findings of the field project, focusing on racism and mental health during COVID-19. Then I will share the overview and findings of the CS HERA study, focusing on the social and economic impact of COVID-19. And then I'll open up for a Q&A and discussion at the end. So I'll begin with the field project, also known as the Filipino Lived Experiences During COVID-19. Specifically, I'll share the findings related to racism and mental health in the community. So the field project was a pilot project that was led by Dr. Melanie Sabato-Liwag, and it was funded by the Fred Hutchinson Cancer Center and the National Cancer Institute GMAP program, and the Filipino American Service Group, a nonprofit that provides direct service that's based in Los Angeles. It was a community-driven and community partner project that was meant to capture COVID-19 related experiences among Filipino Americans living in California. It was also a direct response to the invisibility felt by Filipino American communities and to the fact that no one was collecting this information at that time. Along with our community partners, we've utilized our digital tools to creating a project page where we provided information and resources, as well as running a calendar of virtual and community-led events being held during the pandemic. So some little tidbits about Filipino Americans. Filipino Americans are the third largest ethnic minority in the US and the second largest Asian American minority. They face a disproportionate burden of chronic health disparities, which was exacerbated by the pandemic. For instance, they have had a higher incidence of heart disease and stroke, high rates of hypertensive disorders, and low rates of screening for breast, cervical, and prostate cancer. Historically, the invisibility felt among Filipino Americans is tied to biasing practices. For example, the perpetuation of the model minority myth and the homogenizing of the Asian American and Pacific Islanders in national data. During the pandemic, it was also tied to the fact that Filipino Americans made up 31% of healthcare worker deaths in California by 2021, despite making up only 3% of the population. And in the US, they made up 4% of nurses and 32% of nursing deaths. COVID's impact on this community was made worse by pre-existing health conditions, having less access to quality healthcare, and living in multi-generational households that make isolation and quarantining nearly impossible. And also the collectivist values of the Filipino culture of self-sacrifice when caring for loved ones uh, was made worse during COVID. The burden of COVID-19 imposed on Filipino Americans was also made worse with the rise of anti-Asian hate. Traditionally, we've seen racism measured almost exclusively at the interpersonal level. Recently, we've made progress in measuring at multiple levels. We know that these levels intersect and are not mutually exclusive. We're learning that their effects can be cumulative on mental health and also physical health. And with the field project, we became interested in the people's experiences with racial discrimination and its relationship to mental health during the pandemic. We also hypothesized that poor mental health was associated with racial discrimination among Filipino Americans. The focal point of the field project was a comprehensive survey that was initially launched in March of 2021. Because of social distancing measures, we recruited remotely, mainly through our website, through social media, and also through our partnered community-based organization. The launching of the survey was originally planned for the fall of 2020, but because of the heightened anxiety and stress caused by the 2020 presidential election and also the George Floyd protests, we pushed it to after the inauguration in January. Then we realized that during that time, the COVID vaccine was also becoming widely available. So we slightly delayed the launch of our project, but by delaying the project, we were able to obtain more information, especially about vaccination experiences during that time. Our final sample of the size for the survey was 223, and this is within the greater Los Angeles area. Majority of our sample was younger. They were ranging from the ages 18 to 35. Many were female and many were highly educated, and about half were born outside of the US. A third were employed in the healthcare industry and half were frontline or essential workers. More than a third lived in multi-generational households, and 41% reported having a pre-existing health condition that was diagnosed before the pandemic. There's a lot more that I don't have time to go over, but if you're interested, you can scan the QR code at the corner shown here, which will take you to a preliminary paper that we published on this project. So we've asked respondents health related quality of life within the past 30 days when taking the survey. Majority reported that they had poor physical and mental health for 1 or more days. More than 70% also reported poor physical health or poor mental health that had kept them from doing their usual daily activities. And despite these numbers, a third of our sample reported needing mental health and not getting it. And 44% did not know how to seek help. This shows us not only a lack of knowledge or resources for mental health care, but of mental health stigma within the Filipino American community. Stigma surrounding mental health was a huge barrier to care, and more so in collectivist cultures because of shame and the guilt attached to seeking care. We've also measured the psychological distress using the Kessler Psychological Distress Scale and symptoms of depression using the Patient Health Questionnaire Quick Depression Assessment. 23% of our sample scored high for severe psychological distress, and 86% scored having a moderate to severe cause of depression. 20% experienced suicidal ideation, and the national average for suicidal ideation in 2020 before the pandemic was at 11%. However, we have not conducted a comparison of our data with the national averages, which we will assess with data released in 2021 from the Behavioral Risk Factor Surveillance System. The majority of our respondents also reported ever experiencing racism when seeking medical care, getting a job, and at work. Logistic regressions on each of these settings indicated significantly strong associations with poor mental health, specifically using the psychological distress scale and also the quality of life assessment. Most respondents also reported experiencing discriminations from their own ethnic background, indicating some degree of not only interpersonal racism, but also internalized racism. When we asked why they thought they experienced discrimination, the top two reasons that were reported were because of their ethnicity and because of their appearance. Within the Filipino community, a lot of people experience sort of having to contend to the color of their skin, whether they have darker skin complexion or lighter skin complexion, and that's usually when they talk about their appearance. But also, we talk about body weight stigma, those who are overweight or appear overweight, and also questions around pregnancy come up within family groups. And then the two least reported reasons were that they were perceived as having caused the COVID-19 pandemic or being labeled as illegal immigrants. It is possible that the last two reasons are related to the racist rhetoric dominating the COVID-19 coverage at that time. And the top two reasons may be the experiences related to before the pandemic. We don't know for sure, but we've conducted focus groups and also individual interviews with some of our participants, and they've talked about their experiences within the family dynamic about having to contend to these issues around appearance and also just being Filipino. We plan on exploring this more in the future by comparing other people's experiences pre and post COVID using the everyday discrimination scale. For almost half of our respondents, their experiences were slightly to somewhat stressful. 36%, they were very to moderately stressful. And the additional regression showed a significant association between these stress levels and poor mental health. The majority also reported very to moderately stressful experiences with their health, their jobs and finances, and within their personal relationships. And all goes to show the degree of instability that was felt during the pandemic. And these are issues that could be compounded by racism, and together they can certainly have a cumulative impact on mental health. There are likely distal and proximal factors that compound the Filipino American experiences that we are not accounting for. For example, the deficits in resources, in the lack of investment and research on the community, and also the generational effects of colonialism. We saw this earlier with the 70% of our sample reporting discrimination from their own people of their own ethnicity. And it's possible that this form of discrimination stems from a colonial mentality and the feeling of racial inferiority. So with the FIL project, our core question was, how do we move forward to achieve visibility for Filipino Americans? So by using a comprehensive approach to research and healthcare that invites cultural humility and a more holistic perspective beyond temporary downstream solutions, and because the effects of racism and colonialism took generations to entrench themselves in the community, we need to uproot them which might take just as long and will require a very long-term effort using upstream effort. We can also leverage the expertise of the community in addressing these issues first and foremost by acknowledging the value of the existing resources without hyper-focusing on the deficits. We also must continue to make visible the community's ongoing struggles with COVID-19. And as we ended the COVID-19 public health emergency last year, we'll have to consider the impacts of long COVID and what that could look like in the long term. So next, I want to pivot to the next project, the See Us Hear Us project, also known as SUHU, which I'll be calling that, and share a bit about the findings on the social and economic impact of COVID on the representative Southeast Asian community group being presented in this study. So the SUHU study was funded by the National Institute of Minority Health and Health Disparities as part of the Rapid Acceleration of Diagnostics, or the RADx initiative. And the aim of this study is to collect individual level data about the social, ethical, and behavioral implications of COVID-19 testing, vaccination, and its sequelae among Southeast Asian Americans in the greater Los Angeles area. For this study, we've utilized a community partner participatory research approach, and we've been working with 6 community-based organizations within the greater Los Angeles area. So here's some background. So as of 2020, approximately 2.5 million Southeast Asian Americans live in the US, making up an estimated 10% of the total Asian American population. Other groups like East Asians or the South Asians make up the other 90%. Southeast Asians are mostly foreign-born, first and second generation Americans, and California is home to the largest population of Southeast Asians. The 4 largest groups in the greater LA area where our study is based are the Filipinos, the Vietnamese, Thai, and Cambodians. Therefore, for the purpose of a robust sample, we focused on these 4 ethnic groups. Southeast Asians are a diverse and distinct group. They are varied in linguistic landscapes and a multitude of traditions and religions, and they have very different immigration patterns. Filipino Americans, for example, were the first to arrive into the US, whereas the Thai community possesses a relatively recent history of immigration to the United States. Occupation also vary widely within the Southeast Asian communities, spanning industries such as restaurant service and healthcare. Southeast Asians are also a community in need. Previous research has shown that many of them are undocumented, hold low-wage jobs, and are less likely to attend college and struggle with health challenges such as hypertension and diabetes and among other chronic diseases. This is data from the US Department of Commerce, which show the percentage of adults 25 years or older who hold a bachelor's degree. And if you can see, the figures are at or just under 50% for Southeast Asians, with Cambodians at the lowest rate with only 16%. For this study, for the SUHU study, we developed a comprehensive longitudinal survey similar to what was created for the field project that participants will take over a 12-month period at 4 time points, baseline at 3 months, 6 months, and then at 12 months. So I'll be sharing the findings from only our baseline data today. The survey is made up of pre-existing questions from the RADx common data element, which included demographics and COVID-19 questions, as well as additional questions based on the community needs, some which included questions on remittances and racism and discrimination. In the interest of time, I won't go into in depth with all the demographics, but rather highlight a few key things. Firstly, our sample is made up of 400 participants, 23 Cambodians, 141 Filipinos, 93 Thai, and 90 Vietnamese, and 53 multi-ethnic or others. The mean age is around 36 years old. However, among the Thai survey, the mean age was slightly older at 47 years old. Nearly 50% of our participants reported receiving a bachelor's degree, and compared to the data that I shared about from the Department of Commerce, where I stated that many did not have a bachelor's degree. While we don't have supporting data here today, our findings also showed that many received their education in another country. So while Southeast Asian immigrants may have had higher education in their home country, unfortunately, due to the systemic barriers, their degrees are often not seen as equivalent to the degrees here in the United States. And that contributes to the income disparities within our sample. Despite many holding a bachelor's degree, be it foreign or even in the US, nearly 50% from our sample reported making under 50,000 a year. And majority are supporting anywhere from 2 to 6 people with their income. And additionally, many reported either living with their family or in multi-generational households with 3 or 4 generations under one roof. So this is some of our COVID data collected at baseline. As you can see, 95% reported receiving a COVID-19 vaccine at the time they took the survey, with Cambodians, although a smaller subsample, having the lowest vaccination rates. Approximately half of our sample reported experiencing job loss due to COVID-19. And more than half reported experiencing quarantine challenges. As previously noted, many are living with family members, some in multi-generational homes, and therefore a lot of people can make it difficult to isolate, especially if homes are not big or spacious. More than 50% of our sample reported testing positive for COVID-19, and similarly, of those who tested positive, 50% experienced job loss during COVID. When we look at the data collected by immigration status, we see a shift in the mean of age. Among those who are US born, they tend to be younger at 28 years, and these are first generation. Whereas those who are naturalized or non-citizens, such as green card holders, undocumented immigrants, or refugees, those who prefer not to answer, they tend to be older. All groups experience COVID-19 quarantine challenges by immigration status. And among Thai, over a quarter reported experiencing ongoing financial strain and fear of losing their jobs with varying degrees of stress. So we range them from very stressful to moderately stressful and not very stressful. Among Filipinos, approximately 40% experience ongoing difficulty with their job or ability to work, while just over 50% reported ongoing financial strain. Among the Vietnamese, nearly 50% also reported ongoing financial strain, and over a quarter reported experiencing difficulty in a relationship with someone close to them. And lastly, among Cambodians, over 75% experienced ongoing financial strain due to COVID, and over half experienced difficulty in a relationship with someone close to them. So we started to wonder why this was the case. For the social challenges among Cambodians and Vietnamese, as both reported the highest rates. And when we talked to some of our key stakeholders, they stated that COVID-19 has brought back PTSD, or post-traumatic stress, of events that had happened in their home countries. For example, for Cambodians, it was the Khmer Rouge. For the Vietnamese, it was the fall of Saigon and having to leave their countries during that time. And these are generational effects that they brought with them and sort of impacted their social and mental well-being. And lastly, among non-citizens, approximately 50% reported experiencing seriously ongoing health problems during COVID, while nearly 85% reported ongoing difficulty with their job or their ability to work. So to conclude, our sample from the SUHU study at baseline, a population was a population that really struggled during the pandemic, experiencing high rates of job loss, ongoing financial strain, quarantine challenges, and also social challenges. So this study really calls on others in public health to contribute to the efforts on collecting data in disaggregate form. It is needed and emphasizes the need to understand the nuances among the small and minoritized populations. So if you'd like to keep up with the CS HERA study, here's the QR code. And we have a website which has both the Suhu study and also the field project. Um, I also want to thank the institutions and community-based organizations that have made the CS HERA study project possible. These are the 6 organizations that are a part of the study and have helped with hosting events as well as enrolling our participants into the study. And lastly, I want to express my gratitude for your time. I will now open the floor to questions and discussion. I'll leave my information and contact on the screen for you.
I guess I can go first. I have my question written in the chat, but how do you suggest we approach community members to start these conversations and encourage them to share their lived experience? Since I know that people in our communities, they're afraid to talk about it, and they feel like there's a lot of stigma in sharing their struggles as well too.
Yeah, so our approach was not to reach out to individuals directly. Um, so this was one of the reasons why we collaborated with organizations, because these become sort of the community and gateway to bringing these people together, to allow that comfortability of community members to kind of build coalition, but also to kind of be more open to having these discussions, whether it be about their own personal health and well-being, or getting resources to kind of tend to sort of what's going on within their own self or within their own families. So this is one of the reasons why like we partnered with these organizations, so that it's not sort of attacking or like, intrusive to getting these participants to provide this information for once in an office survey. Does anyone sort of relate to any of these issues at all that was presented within the different Asian American, Southeast Asian groups? I know each Asian ethnic group had their own type of sort of issues, but like I feel being under the Asian American umbrella, we do find some similarities and experiences that we can relate to. So I'm wondering if anyone has any particular related experience to anything that I've shared today.
I definitely relate to the intergenerational responsibilities and feeling like one income is stretched between many mouths to feed, or all living under one roof, especially
Yeah.
if you're in dense urban areas. That was part of the question I had too around like where should public health officials begin doing this type of work? I thought it was interesting how a lot of the average age of the participants is around mid 30s, and I imagine that group is feeling a lot of strain, where maybe playing some caregiver roles for older members, but also like living as a minority in a majority culture in the States, and like having pressures around assimilating or being more American. So I'm wondering, from a public health perspective, are there different tactics between like helping to provide better resources for younger Asian Americans versus older Asian Americans, or is it better to take like an age-based approach or an ethnic-based approach? Or if there's any other public health officials, like I'm not a public health official. So I'm just kind of wondering what do you do next with this type of information? There's like clearly a need, but where do you start?
Thank you, Angel. So with our findings, we definitely will be sharing this back to the organizations. And I know the missions and goals of the different organizations, partner organizations that we've worked with are very different. Some are direct service providers, some are just community-based coalitions who don't provide any type of direct resource or service. But what they all are doing are providing information and connecting individuals to sort of the need that's needed or what has been found within the data that's being provided to them. So they are connected to the LA Department of Health or the Department of Mental Health, and also to the network of hospitals and clinics around the area if needed to sort of contend to these issues. And for like the sort of financial things that I talked about, those are also connected to the organizations, like upskilling and building these skills to find a job, and connected to networks where they can find like temporary assistance to a job network that will lead them into a more permanent position. Very diverse resources across the six community-based organizations that we've connected with through the CS Here project. But I think just the biggest barrier is that the community does not know that these are being provided. So what we're trying to do is try help with the marketing of and the resources and information that's being shared within the organizations to the larger community. And that definitely takes a bit of effort. So that's why we have like our website and our social media pages and connect them to these six organizations and the other organizations that have been a part of our research work.
Yes, I see Tina has her hand raised, and then we can go to Catherine's question in the chat. So Tina, do you want to share your question or thought?
Yes, thank you. I was wondering if there are efforts to combine this type of information with similar types of studies of other immigrant groups in California. So the reason I ask about that is because I was really struck by what you said around the 51% job loss during COVID. I know a lot of other immigrant communities. I'm based here in Massachusetts. I know in Massachusetts, a lot of Latino communities were also greatly impacted by job loss during COVID. And it just seems like this is a really great opportunity to show that, America does run on immigrant labor. And when there is a pandemic, we need to make sure that everyone is taken care of. So not just those who could apply for unemployment benefits, but also people who may work in an informal economy. And I know there are efforts happening around the country regarding guaranteed income, and those like regular cash payments are no strings attached, and also regardless of immigration status. So I just wanted to bring up those thoughts.
Yeah, thank you for sharing that, Tina. So because this is part of a national effort, so I mentioned that this was funded by the RADX initiative. We do share this information back to NIH, which funded this project, which we're hoping will compile all of like sort of the projects that they funded and find relations to sort of the topic that you talked about, whether it be under immigrant health or minority health or Asian American health. But on our end, we're also making the effort to disseminate this within these affinity groups or the special topics. Last year, we presented this within an immigrant health forum in California, and also at APHA, or the American Public Health Association National Conference. Um, and we and it's not only us that is sharing this information. We're also engaging with the community-based organizations who have to do the reporting for their own organization to include some of the data that we've collected within the reports, so that like this is being shared within their network and whoever's funding them, so that like this is being told and publicized.
Hi, Jake. Yeah.
I
I have a question. I mean, I'm from a Southeast Asian background. I'm from Pakistan, and it really struck me by when you mentioned in the beginning slides that some of the disparities also are also due to skin color. And the first thought I had was, and it's very basic, but it's very huge, and it's been a huge phenomena in India as well. A lot of people, like a lot of girls, especially when they're born over there, it's this like generational trauma that they get, that everyone wants them to be of white color, to be like of fair skin, and all these and the skin color is a huge deal in India and Pakistan, and everyone wants to be fair. But when the firstborn or the second generations come to America, they've kind of realized that it's not such a big deal. Our tan skin is actually really admired over here. So, and I feel like these these things that constantly, these generational traumas are actually provided through our families as well, and it's due to constantly being told that this is not right, and your skin color would not make you, like, you won't get married because of it, and so on and so forth. So, my question is that how do you basically what strategies can be implemented to address these disparities within families effectively?
Yeah.
Yeah.
So part of this collaborative that we have called the Happy Lab, so it's a huge, we're not huge yet, but like they're based out of Cal State Northridge. And we have many students who are sort of identifying what work they would like to be take on as researchers and further studies. And one of them was on skin color, and it was through the instance of finding this core data piece within our study. And she is now focusing on that and talking about the generational effects of skin color and sort of that colonial mentality on white versus dark skin within her work. So we're hoping that would take off. I think she's in her second year, so I think she will be continuing this work, focusing on that. So that's where we find sort of uplifting sort of the nuances and pieces within the data, so that like if someone wants to do some research on it, they're more than welcome to kind of uplift that.
I also just wanted to make sure Catherine's question was touched upon before we go to the other hand. So Catherine had written, I'm curious to see if there's a plan to share the research with the community. What are your hopes for the CBOs and organizations to use this information in research?
Yeah. So with the community-based organizations that we partnered through the study, we have regular monthly meetings in which sort of these waves of follow-up surveys are being disseminated, and the preliminary data that we pulled out are being shared within these meetings. And then we're hoping at the end of the study, I believe we're wrapping up this year, we're going to be sort of compiling a more comprehensive report, hopefully through published papers as well, in which it's not only us as the academics who are writing these papers, but also the community-based organizations who are contributing to building these pieces of work, whether it be a report, a white paper, or a research paper. And they can use it to whatever they desire within their funding lines or in their own reporting, as I've mentioned earlier. And we're hoping that that sort of become that domino effect of dissemination of this information.
Maybe Johnny can go next, then Jennifer.
Sure. I'm just gonna lower my hands for now. Hi Jake. So I'm actually curious about so we've been talking about, like how we're gonna use the information, to help increase raise awareness or to work with other health decision makers. But I'm actually curious about the two studies in terms of challenges. So my question is, have you encountered any challenges in, let's say, because the study work with a lot of diverse groups, ethnicity, population. So I'm curious to see if you guys encounter any challenges in bringing in participants, kind of helping them engage in the research. For example, someone maybe say they interest, but then they don't want to participate, or or maybe they don't understand something and they're confused. So, like there will be certain problem challenges that you encounter, and I would love to learn more about that and how you guys overcome that, or encourage people to participate in the studies.
Thank you for your question, Johnny. Yeah, no, we've encountered a lot of challenges for the two studies. For both projects, actually, because this was during COVID, it was difficult to sort of disseminate these surveys. So we resorted to sort of mail, but even touching mail became sort of a dangerous thing. So that's why we initially started in the healthcare or hospital setting, where the nurses were the ones who were talking to participants about the study and sort of engaging sort of patients within the clinical setting to share about the project. Um, and then within the different community-based organizations that we partnered with, they have lots of community events that they hold. For the Thai community, for example, we actually went out to the Thai temple every Saturday. Um, well, and I think one of our biggest challenges is we didn't have quite of a large team at that time. So it was mainly only one or two people doing outreach and sharing information. They had an iPad with like a QR code, so it's like a safe sort of way to kind of share the information. And through that, they were able to enroll into the study, and then they would be sent a link where they can take the survey. Um, Also, another challenge was the incentives. We want to ensure that our participants are being paid for participating in the study. So finding funding for that. We were grateful that our projects were funded by very large organizations who were able to provide us with some funds to allow us to provide incentives for our participants. And that way that would keep them to stay into the study when we do these follow-ups. We have had some drop-off within the 4 and 6 months, but we're hoping a majority of our sample is still with us at the end. So those are just like some of the key challenges, and also just scheduling the meetings with the community-based organizations. While we only have one person representing one organization, we want to ensure that like we have multiple perspectives. So we make the effort to kind of drive out to where they are and ensure that our participation is engaged with what they've been doing within their own work, but also how they can be involved within the larger study.
Awesome. I guess I'll go next. Hi, Jake. It's nice to meet you, and thank you for sharing your research today with us. So I think I have a couple of questions. Hopefully, I can remember them. I guess my first question was about the fillable study and how there was like a lot of mention about mental health issues. I was just wondering if you have like any resources or organizations that that are doing the work that you guys can uplift, because it's really cool to hear that you guys are working with organizations that are doing this work.
Yeah. So for the field project, as I mentioned, we use a lot of digital tools. So on our website, we actually have a page of resources that have connected them to the Department of Public Health in Los Angeles, but also sort of, I think there is one key Filipino helpline that people can call. I believe it's called Tayo Help. And they were a partnered organization that helped us uplift the study as well. So they were like the main line during the pandemic, doing outreach to the Filipino community, providing resources about like mental health awareness, how to contend to sort of getting vaccinated, or like what can they do within their home to stay safe from COVID. And it's like a bunch of operators nationwide, um, and from different parts of the country, who I don't know if all of them are Filipino, but like have the expertise of like the Filipino American community, but also are trained mental health counselors to provide. I I mean, they definitely aren't like the direct service, but they would link them to if they need to see like a mental health specialist or a counselor within that scope of the intensity of their sort of mental well-being.
That's really awesome to hear. I didn't know that was a thing, so thanks for sharing. I guess this is my second question is more of a thought question. I'm an MPH student, so and this is like an area of particular focus that I really am interested in learning more about and like doing research in the future. But I was just curious about, since the studies that you've worked on are mainly focused on the West Coast and specifically California, do you think there would be differences if we did different studies in like the East Coast or like specific regions in that area?
Yeah, no, I mean they're particularly for the Filipino community, American community. Uh, Within my own work, I've seen sort of the differences between the Filipino community within. So I'm originally from Hawaii. So the Filipino community in Hawaii is very different from the Filipino community on the continental US. And I know that there are regional differences between NorCal and SoCal, and then also East and West Coast. Um, but I think having understand that there are regional differences, what we try to find is what across the different regions, what are things that are very similar and what are things that are not, and how do we contend to those sort of regional differences and not sort of crab pick or like sort of have that crab mentality and like pick upon like these differences, but rather understand that we are one and the same, but not necessarily. And how do we celebrate those differences and not pinpoint on them?
Yeah, that makes perfect sense. I guess my last question is just like, what the throw out question that everyone does is like, what does the future look for you, and like what are the directions of the lab and
So,
do you see?
so while I'm sort of moving on into, so I currently a postdoc, but now moving into a faculty position at a different institution. I am still going to be affiliated with the Healthy Asian and Pacific Islander Lab that's based in Cal State Northridge. Um, and with this data, there's a lot to sort of publish and to disseminate and to share. Um, a lot of my work is community-based, so I'm hoping to continue that work to engage with the community-based organizations that who are a part of this project, but also find organizations who are in need of like research sort of approaches and finding um, the information to kind of build upon their own narrative and understand their own needs and how to uplift them.
Awesome. Thanks again for the presentation and sharing.
And then Jennifer, if you're wanting to dig into this data, I'm more than welcome to like link you up to our two lead investigators in this project.
Awesome. Thank you. I might reach out to you.
Very cool. Awesome. Well, I want to be mindful of time. I know Sophia has some announcements. And then yeah, if people have final questions can put it in the chat. But thanks so much, Jake, for sharing that. And thanks so much everyone for doing the Tea Talk series. This is one of the last ones that Anise will be doing. So just wanted to say on behalf of Anise, it's been such a pleasure to partner, and thank you so much for working together. It now feels like a friendship and a family over several months. So just wanted to say thank you everyone from Asian Women for Health for putting this together too. Back to Sophia.
Thank you, Angel. It's been so great working with you as well too. Let me